Good morning, everyone. My name is Whitney High. I'm a dermatologist and dermatopathologist in Colorado. I'm the director of the dermatology clinic and the director of the dermatopathology service there. It's my pleasure this morning to begin the session. We're having our first session on hyperhidrosis, no sweat, chaired by Dr. Pariser and with Dr. Deanna Glaser. So I'll turn the microphone over to them and they can show us how treating hyperhidrosis is a cool breeze. Thank you.
Well, welcome everybody in the room and wherever else you are to this session. We're going to try to make this a little informal and perhaps a little interactive if we have time at the end. First, introduce to those of you who don't know her, Dr. Deanna Glaser, who has worn many hats during this seminar, but is here today to talk with us about some challenges of hyperhidrosis.
So it's really a pleasure to be here. I do have some disclosures. I think most importantly is I'm going to be talking off-label about many different treatments. We tried to divide this session up so that I'll be talking to you about devices and injectables, and then Dr. Pariser will talk more about topical and drug management and sort of what's new and what's coming, which we're all excited about. So yesterday I mentioned that the prevalence of hyperhidrosis is more than what we have previously thought. It's close to 5%, and that really is similar to other countries throughout the world. We also know that most patients, about 50% of people who have this, still are not seeking help from a healthcare provider, which is really sad, and that's because they don't think that there's any treatments and they don't think that it's a real medical condition. So again, I'm going to talk about some of the devices, and what I really want you to start to think about is how it will be to combine different treatments. That just like all the other diseases that we treat, we're not really using monotherapy, we're using multiple therapies to bring in and optimize the results and minimize any side effects. I think the important thing to remember is that most of these patients have multiple different body areas that have sweating. And ideally, if you can use a focal treatment to that area, that's going to be the safest and usually the best. But you've got to find something that's going to treat each and every one of those areas that they have. So they might have hands, feet, underarms, face, scalp, groin, inframammary. They might have multiple of those. And many patients will describe that they have 5 or 6 different body areas. The goal of the treatment is always to improve the sweating, not to make them so that they never sweat, not to make that they never sweat in a stressful situation, but to improve it, to lessen it. And you really have to stress that. You cannot get rid of their sweating. So with that, I want to start with tap water iontophoresis, one of my very favorite and go-to treatments for hand and foot sweating. It's inexpensive. It's definitely old school. You guys have all heard about this for 20 or more years, but it really works well. And the problem is it takes a lot of time to get good results. It takes 3 times a week, 20 minutes usually for one set of extremities, the hands, or 20 minutes for the feet. And if they've got both, now they're up to 40 minutes. So it's labor intensive for the patient. But if you can get them over that hump and they get good results, oftentimes, maintenance therapy, it's once a week, and that's manageable for most patients. Hard water, you can do with just the hands in there, or as the one picture shows, with a hand and a foot, so that then they have one hand to operate a phone, maybe a remote control. But what's nice is now there are some other options besides the Fisher machine. And the Fisher machine has updated. It's got some new bells and whistles that patients like. But there is a machine called Hydrex that is available that came over from Germany. It's FDA cleared here. It actually shortens the treatment time down by 5 minutes each, so 10 minutes total for all 4 extremities. And then Davlin is actually helping by doing the prior authorization for your office staff. So my office loves that. But each of these companies has really opened up and will help you and your practice and your patients get the treatment and the devices that they need. But there are different devices that you can choose from. Remember that pregnancy pacemakers and orthopedic hardware at those treatment sites are contraindications to this. But it really is my go-to treatment, and I try to get people with hand and foot hyperhidrosis to use this. Another device that could be used is microwave thermolysis. And this is FDA cleared for treatment of axillary sweating only. And this uses a very focused ultrasound that delivers heat and energy at the level of the eccrine gland in the axilla. It permanently destroys the eccrine gland, and some of the heat transfers over and actually destroys some of the apocrine gland. So patients will describe that if they had a little bit of body odor issue, that's now resolved with this treatment. Currently, we use high volume anesthesia or tumescent anesthesia, and what that does is it allows us to use higher energies, get better results with one treatment. So when the FDA cleared this device, it was looking at 2 treatments a couple of months apart, but now I would say over 95% of my patients only need 1 treatment with the high volume anesthesia. It takes about 2 hours total in the office by the time we get done. They have about 24 to 48 hours where they need to ice their underarms. They need to kind of chill out. I tell them to binge watch something on Netflix or whatever they have at home and just take it easy and take some non-steroidal anti-inflammatory drugs. But you can see in these histology that the sweat glands are really eliminated after the treatment. And again, apocrine glands as well. So can be a very nice option. Currently, there are absolutely no insurance companies that are covering it. So botulinum toxins is the last of the devices that I wanted to talk about. As you know, there are several different that are botulinum toxin A's that are approved. Botulinum toxin, or the Botox brand, is the only one currently that's approved to treat hyperhidrosis, and it's approved to treat axillary hyperhidrosis. But in truth, many publications are available looking at all of these, and all of them do show efficacy. In Europe, they'll still use some botulinum toxin Bs, which we don't typically use here in the United States. I covered this a little bit yesterday. So the basic principle of using botulinum toxins to treat hyperhidrosis is to identify where the patient is sweating from. You can use a starch iodine test, or you can really get down with a history and help to pinpoint where they're actually sweating from. But starch iodine tests are very helpful. You inject the drug where the eccrine gland sits, which is at the sub-Q dermal junction. Usually we want a little more of a dilute solution, so 4 cc's of saline per 100 units and a 30 gauge or a 31 gauge needle. I like to use a Lurlock. This is just to show you the data that was collected in the phase 3 trials for Botox for the treatment of axillary sweating, looking at the differences between 50 units per underarm versus 75 units per underarm versus placebo. And you can see that between the 2 doses, they both achieved very significant improvement and statistically different compared to the placebo. And even with a second treatment, again, both doses provided excellent results. When you looked at just a simple reduction of more than 75% of the sweat that was produced by the patients, again, both doses, 50 units and 75 units per axilla, achieve the same endpoint. So therefore, when you're treating axillary hyperhidrosis, you want to use 100 units total, 50 units per each axilla. So if you get a starch iodine that has a little tiny axilla that's sweating, you still put all 50 units into it. If you've got a larger axilla, go ahead and distribute the 50 units in that larger surface area. So the way you do a starch iodine is you dry the area, you apply the iodine solution. In my office, we use a betadine swab. It has enough iodine in it. It's easy where it's available. It also cleans off the skin and makes the bacteria go away. So you dry the skin, you put on the iodine, you let that dry, and then you put on cornstarch. And you really do need to use cornstarch. Talcum powder doesn't work as well. Plain old cornstarch that you get from the grocery store, and you'll start to see these blue dots coming up. So the top picture is a positive starch iodine. You can see that this person did not shave their axilla. You don't need to have patients shave their axilla. In the bottom photo, this is a patient whose sweat was not completely dried. So all that smudgy gray-brown color is just indicating where the sweat had been. So really have your office staff dry off that sweat very well. And you can see some of the differences in how this test helps you identify where you need to put the drug. The poor person there on the right, I I don't know that 50 units is going to control them, but that's exactly what I would start with. And if I'm not seeing the results that I think we need to see, then I will go up from 100 units total to 200 units total. But I do start with 50 per underarm. Here's the area has been dried, and now I'm applying the betadine swab. I apply it to an area larger than I think that they might be sweating from, because sometimes I'm quite surprised. It's dried. Now I'm sprinkling on some plain cornstarch. I'm going to rub off the extra, kind of brush that off, and within seconds you'll see these very clear purple-black dots, and that's the area that you need to inject. I don't use this test for hands or feet. I know that their entire palmar and plantar surface are sweating, but this is very helpful for the axilla. It can be very helpful for inframammary and groin. Now what you want to do is, in general, you inject about 1.5 centimeters apart. In the axilla, we know that studies have shown 50 units for the most part per axilla is what you want to use. For non-axillary injections, I'll use about 2.5 units every 1.5 centimeter. And you can see I've tried to space these apart so they're not in rows, so it allows for that diffusion to overlap a little bit. So then we're going to inject. Here's our 4 cc's per 100 units. I've got it in a Lure-Lock 1 cc syringe. I'm getting ready to inject 50 units per each axilla. And it's at a dermal sub-Q junction, and you'll see a little bleb, almost like you're putting on a PPD, and you'll see that bleb. When you're injecting hands and feet, because of the thick stratum corneum, you won't see that bleb. But here you'll see it. And this is really a pain-free injection. I have no anesthesia, anything like that. And most of my patients will use about 12 to 14 injections. So again, a bleb, you'll see it. Now, what happens if you do a starch iodine and the patient is not sweating? Well, try to treat the sweat or the hair-bearing area. And I tell the patient, you're not sweating today. I'm going to treat what I think needs to be treated. If it's not right, come back and we'll take a look at it. So if you don't get a positive starch iodine test in the office, treat the hair-bearing area and have them talk to you in a couple of weeks to see how it's doing. If you miss an area, the patient will complain that they are sweating almost, if not as bad as they were before you did the injection. So the call into your office is, this is not working at all. Have them come in, repeat the starch iodine, and you might see an area like this. And this picture on the left back in 2003 was the first patient that called in before there was any insurance coverage and said, I did not pay you all this money. I did pay you all this money. It's not working. I want my money back. So just pop in a few more units and you'll be good. You can use this off-label for hands, feet, other areas. When you're dealing with hands, you're going to have to just use higher doses. For a small hand like mine, I might use 100 units per hand. For larger hands, I might use 200 units per hand. You've got to think about anesthesia. My favorite is looking at ice, and these are the ice cubes that we use. You can get them at any discount store. These happen to come from Walmart. They're designed for water bottles, so they're these long cylinders. So I can put this ice and chill down several areas and move it as I'm injecting along, and then I can put it up on its end and really push down to try to get some sensitive areas iced down. Forehead, scalps, these are very common areas, the 3 most common patterns that you'll hear from patients. And again, you have to ask, where does the sweat start from? Because once it gets going, it's going to go all over and drip all over the entire scalp. But where does it first start from? So it may be the forehead and the temples. That's one of the more common. It may be the forehead and an ophiasis pattern like you see with alopecia areata, or it could be more globally. So again, how much you're going to put in, these are not well studied, it is off-label. If it's just the forehead and the temples, I'll use about 100 units. If it's the forehead and an ophiasis pattern, I'll use about 200 units. And if it's the whole scalp, they think, then I'll go ahead and use about 300 units. It's still a subcutaneous injection. This is a 13-year-old boy that I treated. It's about 1 centimeter apart. Be sure to warn them that they might have some frontalis muscle effect and might have some asymmetry there. Again, the goal of these treatments, all of them that I've just gone over, is improvement. And what I really try to stress to patients, it's the type of sweating that's occurring when you're not doing anything. It's like if you guys were sweating right now in this cool room, you had no reason to sweat and you're sweating from a focal area. That's what I can most help you with. I can't make the sweat go away when you're exercising, when you're doing laundry and going up and down steps. That's physiologic. That's telling your body that you need to do it. Don't count on that improving. So I hope that in my time I've talked to you about the higher prevalence, that multiple areas are affected. This is an entirely quality of life issue, but it has a huge impact on patients. The more treatments that you add on and the better you make them, the better you make them. They will get better and better on their own as they get confidence that they're not going to be sweating outside. Combination therapies, and you're going to hear more about other therapies to combine with, but these things have very high patient satisfaction, and don't let the frustrations with insurance interfere with your ability to take care of your patients. I'm going to turn it over to Dr. Pariser.
Okay, thanks. Thanks, Deanna. So I have these similar conflicts. I have done clinical trials and been a consultant for all of the companies who are currently making or marketing products for hyperhidrosis. I don't have any proprietary interest in any of these, and I will be talking about off-label uses. So this is kind of the list of the treatments. Dr. Glaser's covered a couple of these, and I want to cover some others. Topical treatment first. This is really the entry-level treatment for everyone who has hyperhidrosis. Virtually 5+% of people in the United States use an antiperspirant, and most of those have aluminum or zirconium salts in them. We do have some prescription aluminum chloride preparations, but they really don't work any better than the so-called clinical strength antiperspirants that we have. Now just quickly, here's how antiperspirants work. In the upper left panel is a diagrammatic representation of the eccrine sweat duct and the surface of the skin. When you apply the antiperspirant, which is diagrammatically indicated by the green with the red circles being the active ingredient, what happens is that the perspiration mixes with and kind of elutes the sweat into the, elutes the active ingredient, the sweat does that, and into the duct, the chemical reaction, chemical change, pH changes cause a physical plug to form, the lower right panel. So that's how antiperspirants work, by forming physical plugs. Some of the over-the-counter antiperspirants, the so-called clinical strength ones, are more effective than the non-clinical strength. The way you know that it is, first of all, you will have the word clinical in its title. Secondly, it will come in a box, and when you look on the shelf in the pharmacy wherever you buy them, the regular antiperspirants don't come in a box. And the second thing is that they'll be about twice as expensive as the regular ones, but they're worth it basically for anyone. The topical antiperspirants work best when they're applied at night because that's when sweating is the least. It should be applied to the dry axilla, and of course these antiperspirants can be used elsewhere on the body other than the axilla. It should not be occluded. The package insert for Drysol, for example, says it should be occluded. Well, it makes no sense. You don't want to occlude the skin. You don't want to drive the agent through the epidermis. You want it to produce that chemical reaction in the sweat ducts. And you say, well, I'm going to wash it off in the morning. What's going to happen? It's not going to be working anymore. Well, you can't wash those plugs out. So by applying it at night, you're going to get your best effect. And if for grooming in the morning, you want to do something that looks nice and smells nice, apply a deodorant, which is not non-medicated, has no antiperspirant qualities. There have been some studies with topical glycopyrrolate over the past years, a topical version of a systemic antihistamine, which we'll talk about in a minute. But their systemic side effects have limited their use, and the irregularities of compounding have limited their use. Now there are a couple of new products on the horizon. The first one that you see there, glycopyrronium tosylate, I'm going to spend some time talking about because that will be available for us by this summer, hopefully, and will provide a new and really effective way for people to treat. So I want to go through the clinical trials for glycopyrronium tosylate for you, since this is something which you will be hearing much more about and will be a product that's going to be in the treatment algorithm for almost everybody with hyperhidrosis. There were two phase 3 clinical trials called ATMOS 1 and 2, the 3.75% glycopyrronium tosylate versus the vehicle. A lot of patients are randomized, and then there's an open label extension that follows this, which I'll talk about later. The FDA requires now for hyperhidrosis registry and approval that there be a patient-reported outcome. And the HDSS, the Hyperhidrosis Disease Severity Scale, used in the past for Botox and for the microwave thermolysis device, is not satisfactory anymore by current standards. So the developers of this had to develop their own patient-reported outcome and have it as a primary endpoint. And unfortunately, because these things are proprietary, each company that's developing a new drug is going to have to develop their own hyperhidrosis patient-reported outcome unless some standardized one becomes available. So for these clinical trials, the co-primary endpoint was the improvement in this 11-point scale of the ASDD, axillary sweating daily diary, and also an absolute change in the sweat production as measured gravimetrically. Patients as young as age 9 were included in this, and that's really admirable, since it's those youngins where hyperhidrosis often starts. And the patients had to have it for at least 6 months duration. They had to have at least 50 milligrams of sweat per 5 minutes in each axilla, and they had to have a score of 4 or greater on that 11-point scale. Also, the HDSS, the old PRO, was used as well, but not as a primary endpoint. Key exclusions for this study were anything that could cause secondary hyperhidrosis, and we heard yesterday about how important it is to distinguish that. Any kind of prior surgical treatment, inadequate washout for other products, and any systemic agents that had anticholinergic effects. This shows the patient disposition, 350-ish patients in each of the 2 trials, 95, 90, or at least 90 or 95% completed in both studies. Patient demographics for this, most were in their 30s, mid-30s, and you can look at the rest of the demographics. A little bit more females than males, and these people sweated a lot. 170, 180 milligrams per 5 minutes of sweat is a lot of sweat. So here's the primary endpoint, the ASDD, axillary sweating daily diary response of a greater to or equal than a 4-point improvement at week 4, the primary endpoint, and there was a statistically significant and relevant difference in patients who used the active drug and the placebo. Looking at the absolute change in the sweat production measured gravimetrically, good statistical significance in one of the 2 studies, but not in the other. However, a predisposed or pre-calculated analysis, pre-specified analysis allowed the exclusion of one particular group of one center that had tremendous outliers in their data, and when that happened, the statistical significance was shown in both studies. This is certainly the response of the ASDD over time to show that as early as week 1 there was some meaningful improvement in the patient's patient-reported outcome in both of the 2 studies, and the measurement of the sweat as well. DLQI is another thing, was a secondary endpoint, and the DLQI did improve, evidenced by a mean change in the mean decrease in the baseline DLQI scores. So this is an anticholinergic. Is it working strictly topically, or is there some kind of systemic effect from this? Well, there were a few treatment-emergent adverse events, most of which were anticholinergic in nature, and most of which were mild to moderate. And here's what they are. Dry mouth is something which was reported in a lot of people. And if you know, with those of us who use systemic anticholinergics, which we'll talk about in a few minutes, are used to these side effects, so it's not anything that gets us all excited. We know how to manage this, and that's really just by holding doses or decreasing the dose. I'm going to say a little bit more about mydriasis in a few minutes. So in the 2 pivotal trials, this drug demonstrated clinically meaningful and statistically significant improvement and was relatively well tolerated. So after the 4-week pivotal trials, a 1-year extension, almost 1-year extension, was carried on basically to see whether efficacy was maintained and whether there was any changes in the safety. There were a number, about 560 patients started, only 200 finished, and that's because after a period of time, the study was stopped because they had enough patients to demonstrate what they needed to demonstrate. It was basically the same demographics as the original study because they were the same patients. And what I really want to show you is what happened over that long period of time. There continued to be, and this is showing baseline of the original study versus the end of the continuation study, open label. And there was a continued maintained improvement in both the HDSS and in the sweat production as measured gravimetrically. Let's hone in a little bit more on the treatment emergent adverse events that occurred with this. Looking on the right side there, the pre-specified anticholinergic events of interest, there were a lot of those, and I want to hone in a little bit on the ophthalmologic ones, just also to make the point that over time, most of these adverse events occurred early in the treatment over the year, and patients either got used to it or were able to manage this by some dose reduction. So let's talk a little bit about mydriasis. It's something which we don't often think about. A patient who comes in like this with one big pupil and one little pupil can be an exciting event for somebody. In fact, one of the patients who had this went to an emergency room, was hospitalized, and worked up for a brain tumor because they had unilateral mydriasis. So what causes mydriasis? Well, usually it's an anticholinergic side effect of anticholinergic drugs, but other things can. And what you really worry about is tumors. But those don't come up that quickly, and of course, when you get the mydriasis from a topical agent like this, it's probably on one eye. It's not because it was systemically absorbed. Most likely it was because the patient got some in their eye. And so warning of patients about this is important. So of the 31 subjects in this trial who had mydriasis, it was specified as unilateral in 23 of those, and in the others it was not specified whether it was bilateral or unilateral. And most of those, 64%, had their event resolved without study drug interruption. So they were just re-instructed not to get the stuff in their eyes, and they continued right on the study with no more mydriasis. A few of them dropped out because of it. They didn't want to continue for that reason. Looking at local skin reactions, any kind of local skin reaction, any kind at all, where you can see the numbers there. There were a few, more than a few total. A little bit of erythema, a little bit of burning and stinging, a little bit of pruritus. Again, almost all mild or moderate, and virtually all managed by slowing down on the dose or some conservative local treatment. So the conclusion of the long-term study was that the glycopyrronium tosylate can continue to be a safe and effective drug. About a third of the patients reported local site reactions, most mild or moderate and easily manageable, and the efficacy was maintained through that time. Now there's another topical product a little farther behind in the development pipeline. This is a gel which is a similar anticholinergic, this one called soft pyrronium bromide. This one has completed phase 2 trials, and it will be a while before we get to see it. Just to show you the top-line results for that, this was a dose-finding study where they used 5, 10, and 15%, and significant, and they also had to develop their own patient-reported outcome for this trial, the HDSM-AX, and you can see that in the 15% bars on the right-hand side, significant improvement, a 2-point change was dose-dependent, 1-point change, a little less, obviously. And the same thing with the patient who got 50% reduction. So topical agents, when used appropriately, are currently available, and we'll have a much better selection of these coming soon. And probably the use of a topical anticholinergic will become part of everybody's treatment algorithm. Talk a little bit about systemic medications in treatment of hyperhidrosis. Say that there are absolutely no systemic medicines that are FDA approved for hyperhidrosis. All of the use of this is off-label based on small case reports or very small case series. And we use it for generalized hyperhidrosis, those who have it. We use it for focal areas, particularly if there's more than one focal area, or as an adjunct to some other kind of treatment. And here again, what is it that we usually use? Anticholinergics. And what are the side effects? The same things that we just talked about with the topical agent. One of our preferred agent is glycopyrrolate. It's one that I normally like to start with. It's a quaternary-amine, meaning it has less blood-brain barrier penetration. Start off in a low dose, 1 milligram BID, and then escalate slowly each week or two by adding an extra milligram until you get to the point where there's enough sweat reduction, hopefully without any of those anticholinergic side effects. We're comfortable in children using glycopyrrolate because there is an oral form that's approved for drooling in children. So we feel safe in using it. Oxybutynin is the second choice for most, and it's also started in a tapered dose. Propranolol is something that can be given on a once-in-a-while basis when you want to stop sweating for a particular reason, and that's can be given as a test dose, should be as a test dose first, be sure it works, and 30 to 60 minutes before an event can make people sweat much less. I want to go real quickly about another new possible product that's a systemic drug, which actually combines oxybutynin in an instant release and pilocarpine in a delayed release to try to combat the sweating, try to combat the side effect of dry mouth. And in a study which was done with this, it's a complicated crossover study where every patient has with their own control and got to use all three of the agents. Making a long story short, this one using the HDSS, there was a significant improvement with the combo, just the same as there was with oxybutynin alone. And looking at the right side, particularly for Palmer, let me just flip over to the last one since we're running out of time. There was much less dry mouth in this study, and the side effects were those which we are used to seeing. So I'm actually going to stop there and see if we have got any. We have a few minutes left. If anybody has any questions they want to ask about the practicalities of treatment for hyperhidrosis, any of the new or emerging therapies.
Does anyone have one question? Dr. Riegel says we have time for one question.
There's a
Yes,
hand
sir.
over here.
Yeah, sometimes there's rebound, especially with surgical correction. Do you ever see that with local treatment, a rebound, sweating on the back, for example?
So compensatory hyperhidrosis is what you're talking about, and that is typically something that happens with ETS surgery, endoscopic sympathectomy, which we're not really talking about today. When you think about it, if you are using botulinum toxin on a small area, or you're treating a relatively focal area in one side, it's not that much percent body surface area that you're denervating and reducing sweat. So it's not really that much of a problem. I don't know, what have you found?
Yeah, there's been a couple little studies looking at it, and has not been seen or measured that there's compensatory sweating with these other treatments. Every once in a while, though, you'll hear a patient who's, you've really treated their underarms beautifully, and then they'll go, wow, I never realized how much my hands actually did sweat. So it may be more of a perception, but when it has been measured and collected, the sweat hasn't been seen to produce compensatory sweating.
Great. Well, thank you very much to our panel.